Good evening and welcome to this educational webinar that is supported by the Ausnutria Nutrition Institute. Nutritional Intervention for Allergy Prevention, What is the Status in 2021? The CME accreditation has been granted by AAFP, the American Academy of Family Physicians, for 1 credit point. The CME accreditation will be given for attending and participating fully in the activity and completed its requirements. If a participant fails to attend the activity in full, he will not be eligible to receive the credit point assigned. This webinar will take the format of a presentation, followed by a short question and answer session. On the upper right-hand side of your screen, you'll find 2 different tabs, a chat tab and a question tab. Please submit your question using the question tab only. You can send your questions while the speaker is presenting, and we expect to have time for 5 or 6 questions at the end of the session. For other questions, please use the contact form on the website www.ausnutria-nutrition-institute.com. Please allow me to introduce you the host of today's webinar, Randolph Happe from Ausnutria. Randolph was trained as a chemist and holds a PhD from the University of Amsterdam in the field of biochemistry and enzymology. After obtaining his PhD, Randolph gained 20 plus years of experience in the food and nutrition industry. He has worked as the contract research organization T&O Food and Nutrition, and thereafter worked in the business-to-business and business-to-consumers industry, including Unilever, IOI Lipid Nutrition, and Bunge Lauders Croklaan. He joined Ausnutria by the end of 2016, where he currently has the honor to lead the research and development team in the Netherlands. Dr. Randolph, up to you.
Many thanks for your kind introduction. A very good morning, good afternoon and good evening to all of you tuning in from all around the globe. My name is Randolph and it's my pleasure to welcome you to today's webinar of the Ausnutria Nutrition Institute. Again, we will offer you an interesting program and are proud with the expert speaking today, who will be introduced shortly by our moderator. Please allow me to give you a short introduction about our company. We are Ausnutria, a Dutch dairy company with strong roots in China via our mother company, Ausnutria Dairy Corporation. Our main mission is to nourish life and growth. We therefore aim to contribute to the health and growth of infants by offering gentle nutrition. We make sure that high quality products are available for our most precious and vulnerable customers. Our products based on goat's milk focus on improving gut health and are naturally easy to digest. We obviously fully support the fact that breastfeeding is the best nutrition for infants. But when breastfeeding is not an option, alternatives may be searched for. Traditionally, cow's milk has been used to produce infant formulas, but it may not be your best bet when getting closer to human milk. Milk from non-bovine sources may give you a head start in getting closer to the functionality and composition of human milk. Our brand Cabrita is a sound marriage of the gentleness of goat's milk and Dutch heritage and expertise. Our products are complete, modern and safe. Cabrita is based on Dutch goat milk. It contains proteins that are naturally easy to digest, and it's a natural source of beneficial components such as milk oligosaccharides. Additional nutrients may be added to supplement the natural richness of goat's milk. Thereby, we focus on improved gut health and easy digestion. The knowledge and latest scientific insights can be found on the website of the Ausnutria Nutrition Institute. Ladies and gentlemen, many thanks for your attention and participation in this webinar. With this, I would like to give the word back to our moderator. Thank you. Goodbye.
To start this webinar, we would like to welcome Professor Hania Szajewska, that is a professor and the chair of the Department of Paediatrics at the Medical University of Warsaw. Until June 2019, she served as the editor-in-chief of the Journal of Pediatric Gastroenterology and Nutrition. Previously, Professor Szajewska served as a member of the Council and then as the General Secretary of the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, ESPGHAN. She also served as the Secretary of the ESPGHAN Committee on Nutrition. Most recently, in January 2019, she joined the board of directors of the International Scientific Association for Probiotics and Prebiotics. Professor Szajewska has board interests in pediatric nutrition, but her research focuses on the effect of early dietary interventions on later outcome, the gut microbiota modifications such as with the probiotic and or prebiotics and diarrheal diseases. She is or has been actively involved in several European Union-funded research projects. She is an enthusiastic advocate for the practice of evidence-based medicine, and she has co-authored more than 320 publications. In 2020, Professor Szajewska has been ranked as one of the world's top 2% most cited researchers. It is a great honor to welcome Professor Szajewska to join us this evening. Professor, up to you.
Hello and welcome to today's webinar on nutritional interventions for allergy prevention. What is the status in 2021? My name is Hania Szajewska. I'm professor and chair of the Department of Pediatrics at the Medical University of Warsaw. My scientific heart belongs to a number of organizations, including ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, ISAP, International Scientific Association for Probiotics and Prebiotics, and last but not least, to EACI, European Academy of Allergy and Clinical Immunology. Let me start my presentation with this BMJ cover. One can call it politically incorrect cover because you can see an infant who is formula fed. However, this cover calls our attention to an extremely common problem in infants and young children, and this is cow's milk allergy in children. Every now and then people are asking this important question: is the number of food allergies increasing or decreasing? And as a matter of fact, many people believe that the percentage of people with food allergy is increasing. However, with few exceptions, there are no data that can clarify whether this is in fact true. And what are the problems with assessing the prevalence of food allergies? Well, there are many. I summarize some of them on this slide. There is a lack of high-quality evidence based on the gold standard of oral food challenges to determine food allergy prevalence. And different studies use different study designs. Studies differ with respect to populations included in the study and diagnostic procedures used to identify food allergies. And last but not least, there are also geographic variation. There is lack of high quality evidence, but there are some exceptions. And one of the exceptions is this Europreval birth cohort study, which was carried out in 9 European centers to evaluate what is the prevalence of some of the food allergies, including cow's milk allergy. And I'm showing this slide to you and the results of this Europreval birth study because it shows nicely that there are geographical differences. The highest risk of cow's milk allergy was shown and documented in countries like UK and the Netherlands, and the lowest risk below 0.3% in Lithuania, Germany, or Greece. So there are national incidences ranging, there are national or geographic variations. Overall, the incidence of challenge-proven cow's milk allergy was 0.54%. There is no ideal study. There were some comments with regard to these Europreval studies that gastrointestinal non-IgE-mediated cow's milk allergy were not adequately captured and therefore underreported in the Europreval study. And this may be because the diagnosis of gastrointestinal cow's milk allergy is difficult and there is an overlap with common functional and infective gastrointestinal conditions. Still, this study is important because in all the centers, the diagnosis was made exactly the same way. The same applies to another part of the Europreval study when they looked at the hen's egg allergy. And again, there were some variations when it comes to national incidences, ranging from below 0.07% in Greece to 2.18% in the UK, And again, there are geographic variations, as you can see here, that this shows you adjusted mean incidence, which is 1.23. And there are a geographic variation, as you can see on these results from Australian Health Nut study. And for egg allergy, hence egg allergy, there was a prevalence 9%. So my summary number one for the prevalences of allergies is food allergies are and will remain a source of concern for the children, their parents, and healthcare professionals. However, they might be, and I did try to show it to you, some geographic variations. Well, food allergy is a big problem. Cow's milk allergy is a big problem. Management is not easy. So, and we all agree that prevention is always better than cure. And people are really interested in early nutritional strategies for preventing allergy. On this slide, I summarize some of these nutritional interventions, and I will discuss each one of them in more detail. In my presentation, very much I will rely on the findings from the systematic review, which was performed by IACI Food Allergy Anaphylaxis Guidelines Group and was published in 2020 in Pediatric Allergy and Immunology. And I will also refer to a very recent document, which was also published by IACI, which are updated guidelines on preventing the development of food allergy in infants and young children. This document refers or addresses IgE-mediated food allergy. On this slide, and this comes from the document which I just showed you, there is an overall summary of effect sizes. Of course, I do not expect you that you will read it in details, but what I would like to call your attention is that, as you can see, for many interventions, there are very limited evidence, 1 or 2 trials. Of course, when we are discussing randomized control trials. But now let me discuss each one of those interventions one by one. Starting with breastfeeding. As a pediatrician, we have recommended breastfeeding. Exclusive breastfeeding for 6 months is a desired goal. But I would like you to reflect for a moment on this statement. Breastfeeding has many benefits for infants, but it may not reduce risk of food allergy. Please reflect whether you strongly agree with this statement, you agree, you are undecided, or you disagree. This presentation does not allow me to see your answer, but it's not so much that I want to see your answer, but I just want you to think about your personal opinion. And now let me comment on it. When you look at breastfeeding and allergy, and you look what is the evidence, that you will see that there are findings, a study showing no association, showing a reduced risk, or showing an increased risk. So this issue remains controversial. The question is why there are inconsistent results. And there are many factors contributing to those inconsistent results, including confounding factors, gender, age. For example, asthma. To make a reliable diagnosis of asthma, you need to have a child who is already at least 4 or 5, 6 years old. Socioeconomic status, family history of atopy, parental smoking, or presence of furry animal in the home. Recruitment and reporting biases may contribute to the inconsistent results. Inability to randomize and blind. There is no ethical committee which would agree to randomly assign children to be infants to be breastfed or formula fed, and blinding is also not possible. So this really contributes the results, of course, immediately in the selection bias. Many studies do not make the distinction between exclusive breastfeeding and any breastfeeding. There may be some imprecise definition, for example, asthma, or for atopic dermatitis, or for food allergy. They also may be reverse causality. Infants at the highest risk of allergy might be breastfed for longer periods And then this longer period of breastfeeding may be considered as responsible for allergic symptoms. So there are many reasons, many factors contributing to those inconsistent results. So the question is, when the results are inconsistent, what to advise? And all scientific organizations, all expert groups agree exclusive or full breastfeeding in all infants for about 6 months is a desired goal. Breastfeeding is important for the other benefits, even if it does not reduce the risk of allergic diseases. And very similar is very recent recommendation from IACI. There is no recommendation for or against using breastfeeding to prevent food allergy in infants and young children, but breastfeeding has many benefits for infants and mothers and should be encouraged whenever possible. But if you look at the rates of exclusive breastfeeding worldwide, you will see it's about 41%. The 2025 target by World Health Assembly is 50%. So we can see that exclusive breastfeeding rates among children under 6 months are well below target. And I am not sure that we will reach to this to 50% in 2025. And even if there will always be a need for human milk substitutes, no matter how successful the promotion of breastfeeding. And this is my summary number 2. Breast is best. However, there was and will always be a need for human milk substitutes. And this brings me to the second statement, which I would like you to reflect on. And this is, if breastfeeding is insufficient or not possible, hydrolyzed cow's milk-based formula should be used for infants at high risk for the first 4 months. And again, please think whether you strongly agree, you are undecided, or you disagree. So you know now your own opinion, and let's have a look what is the evidence. As you know, when it comes to hydrolyzed formula, there are 2 major types. These are partially hydrolyzed formula or extensively hydrolyzed formula. And of course, we do have amino acid formula, which is really the mixture of amino acids. And there are different indications for the use of each one of them. Here on this slide, I showed you that until 2016, all societies recommended formulas with documented reduced allergenicity in high-risk population. High-risk populations, I mean for allergic diseases, and this was usually defined that there is a positive history of allergic diseases, documented positive history in the family. But then the situation has changed, and this was very much caused by this systematic review and meta-analysis which was published in BMJ and by Robert Boyle and his colleagues. And this meta-analysis concluded there is no consistent evidence to support the use of hydrolyzed formula for the prevention of allergic diseases. Allow me to comment on this meta-analysis. Not all hydrolyzed formula provide the same degree of protective benefits. And this is because factors such as the protein source, hydrolysis method, and degree of hydrolysis that often depend on the manufacturer contribute to differences among hydrolysates. And even if partially hydrolyzed and extensively hydrolyzed formulas were evaluated separately within each one of those groups, please remember that within each group, not all hydrolyzed formula are the same. Because, allow me to repeat again, protein source, hydrolysis method, they are very important, may contribute to the differences among hydrolysates. Those, the efficacy and safety should be established for each hydrolyzed formula, from each manufacturer, I would say. And keeping this in mind, together with my colleagues, already some time ago, we published this systematic review that we looked at partially hydrolyzed 100% wheat formula and the risk of allergy. And so we only focus on one very specific type of formula. And we concluded that there is evidence to consider use of partially hydrolyzed formula as an option for reducing the risk of all allergic diseases, particularly eczema, because we showed in our meta-analysis that there was reduction at least at some time point intervals, although not all. Certainty of the evidence was low, and one characteristic that made our meta-analysis distinct from other reviews is that it focused exclusively on only one type of partially hydrolyzed formula. There is another systematic review, which is a Cochrane review, and this Cochrane review concluded there is no evidence to support short-term or prolonged feeding with a hydrolyzed formula compared with cow's milk formula for prevention of allergic diseases. So altogether, when you look at hydrolyzed formula for reducing the risk of allergy, there are at least 3 systematic reviews and meta-analyses published recently with inconsistent results, which I briefly summarize. So the findings were not consistent. So you may ask yourself why meta-analyses may reach different conclusions, even if they were published more or less at the same time. And on this slide, I summarize the reasons why the meta-analysis may reach different conclusions. First, study design. One should consider whether randomized controlled trials only were included. If non-randomized controlled trials were also included, were they evaluated separately? One should check participants to check whether studies were carried out in both a high-risk population and in the general population, because if both populations were included, they should be evaluated separately. Intervention, and this is probably the most important take-home message. Consider that not all hydrolyzed formulas are equal. And finally, for outcomes, consider whether they assess the same outcome and check how the diagnosis of an allergic disease was made, because differences of any of those may lead to different conclusions. And also, if you look at those 3 meta-analyses, systematic reviews and meta-analysis, which I just showed you, you can see that there were differences in the study selection. So this is our systematic review and the Cochrane review, and only some of those studies, because our aim was slightly different. And also, if you look at the Cochrane review and the BMJ review, again, you will see that many studies were included in both, not all of them. So this may explain why the authors reach different conclusions. But then an important question is, and this is something that probably you may wish to answer first yourself, would you recommend hydrolyzed formula to prevent allergy? So please answer yourself, and I will show you what are the recommendations. And as you can see here on this slide, the recommendations are not consistent. There are some recommendations, some guidelines recommended, for example, partially hydrolyzed formulas, wheat formulas with documented safety and efficacy that they may be considered for all infants. But other societies, including British Society of Allergy and Clinical Immunology, they recommend against the use of a hypoallergenic formula. American Academy of Paediatrics in 2019 concluding there is lack of evidence that partially hydrolyzed formula or extensively hydrolyzed formula prevent atopic disease. And finally, let me focus on most recent document, EACI document, which once again, allow me to remind you, refers to IgE-mediated food allergy. And the statement here is there is no recommendation for or against using partially or extensively hydrolyzed formula to prevent food allergy in infants and young children. What are the practical implications of this document? breastfeeding in all infants is preferable. But when a breast milk substitute is needed, professionals could help families consider the best possible alternative for family individual circumstances, and the options discussed could include a hydrolyzed infant formula. Because, allow me to repeat, there is no recommendation for or against. And this is because of the problems that we have with the evidence. Similar conclusions, by the way, was reached by the expert groups, and this was an expert group led by Professor Ivan van den Plas from Belgium. And here the conclusion is, at present, there is insufficient evidence for or against the routine recommendation of partially hydrolyzed formula for allergy prevention when compared to intact protein feed. And there is some evidence that meta-analysis focusing on trials with a similar design and one selected hydrolysate may conclude that there is some effect on allergy prevention, mainly atopic dermatitis. So the decision is yours. However, please remember that there are some newer studies or newer results, and I would like to discuss them in more detail. After all these guidelines were published, the 20-year follow-up of the Gini study was also published. And this is a study which is probably well known to you because it was discussed for the last 20 years, if not more, at various meetings. So only very briefly will allow me to remind you that it was a double-blind randomized controlled trial. At least at the very beginning, it was double-blind in high-risk population. And the interventions, there were 3 types of hydrolyzed formula: partially hydrolyzed wheat formula, extensively hydrolyzed wheat formula, and extensively hydrolyzed casein formula. And the comparison was a randomly assigned group was with a regular cow's milk formula fed group and non-randomized reference groups. And these investigators looked at the number of outcomes such as atopic dermatitis, allergic urticaria, food allergy manifestation in the GI tract, allergic rhinitis, and asthma. What is important in this study that the diagnosis was confirmed by a second physician, a trained allergologist, again, especially at the very early during the first 3 years of life, so when it was still blinded. And for funding, it was governmental grant. And this is the study which showed that at least until 6 years of age, their allergy preventing effect was documented for 2 types of formula. And these were extensively hydrolyzed casein formulas and partially hydrolyzed wheat formula. And this allergy preventive effect has been seen and persisted until 6 years, as you can see on this slide. But also later on, it was when the findings were reported at 15 years. There was reduction for eczema, also for allergic rhinitis, for the same type of formula, and for extensively hydrolyzed casein formula, there was a reduced prevalence of asthma from 18 to 15 years of age. And what is new, and that's why I'm presenting it here, and a 20-year follow-up. This is very impressive. Any one of you who was involved in any kind of clinical trials understands how difficult it is to keep participants in the study, and to keep them for 20 years, it's very impressive. So congratulations to the study team. And here you can see again these beneficial effects for 2 types of formulas: partially hydrolyzed wheat formula and extensively hydrolyzed casein formula. For asthma, for prevalence 16 to 20 years, and for eczema, for cumulative incidence from birth to 20 years. So the conclusion for these 2 types of formula was that there was reduction in the prevalence of asthma after puberty, and those 2 formulas retained their effect on eczema until adulthood. For extensively hydrolyzed wheat formula, the authors did not support the idea, or this formula was not efficient when it comes to preventive effect. So the findings confirm the concept that early nutritional intervention with certain hydrolyzed formula, if exclusive breastfeeding is not feasible, has a preventive effect until adulthood for both eczema and allergic airway manifestation. So let me finalize this part of my presentation of hydrolyzed formula, that the discussion, especially in the context of the Gini study, a 20-year follow-up, is likely to continue. Now let me move to another intervention which is being discussed every now and then, which is avoiding cow's milk-based formula in early childhood. And please again reflect on the following statement. Avoiding cow's milk-based formula may not reduce cow's milk allergy in early childhood when the formula is consumed on a recurring basis. And again, you may strongly agree, you may be undecided, or you disagree. So please reflect on these statements, and I will discuss it in more detail. Okay, this comes again from the systematic review, which was performed by IACI, and you can see that for avoiding standard cow's milk formula, there was a range in the outcomes from 22% decrease to 2% increase. This was based on 7 randomized control trials. And when it comes to avoiding supplement of cow's milk in first week of life, this was based on the results from 1 randomized control trial. There was a 6% decrease. When it comes to the recommendations, which were formulated based on this evidence, so here are the recommendations. In the first week of life, the IACI task force suggests avoiding supplementing with cow's milk formula in breastfed infants in the first week of life to prevent cow's milk allergy in infants and young children. And after the first weeks of life, for infants who need a breast milk substitute, there is again no recommendation for or against the use of regular cow's milk-based infant formula after the first week to prevent food allergy. And here the discussion again may continue. And this is because especially what to do during the very early, the first week or first months of life. Because there are still 2 studies, one by Urashima, which was included and was considered when formulating the guidelines. And this study shows that early cow's milk formula is tied to subsequent allergies in infants. And this study is not included in the, or it's not part of the evidence base because it was published only later on. And Japanese study by Sakihara, which shows a daily ingestion of at least 10 milliliters of cow's milk formula between 1 and 2 months of age prevents the development of cow's milk allergy. So the data are, they are not so easy, by the way, to interpret, but anyway, they are controversial and contradicting, I would say. So the discussion about avoiding cow's milk-based formula is likely to continue. And this brings me to the next intervention, which is of interest, and this is timing of introduction of complementary foods and potentially allergenic foods. Again, please reflect on the following statement. Allergenic foods may be introduced when complementary feeding is commenced anytime after 4 months. And again, please consider whether you strongly agree, you are undecided, or you disagree. So please reflect on it, and I will comment on what is the current evidence and what are the recommendations. So until 2007, 4 allergy societies advocated allergen avoidance for prevention of food allergy. But this changed, and this was mainly because findings from a number of randomized controlled trials, including two studies, which are probably the most important for this discussion. And one is a LEAP study, randomized trial on peanut consumption in infants at risk for peanut allergy, and the EAT study, randomized trial of introduction of allergenic foods in breastfed infants. Both were published in New England Journal of Medicine. Special interest should be on the LEAP study, which some people call as a landmark study because it resulted in definitive changes in infant nutrition. And it's not surprising because if you look at the effect in the avoidance group compared to the consumption group, and the consumption means that the peanuts were introduced early in life, starting 4 to 11 months of age, and they were consumed until 5 years of age. And you can see here, absolute risk reduction was almost 12%, and the relative risk reduction was 87%, with number needed to treat 4. So it's really a landmark study, which really showed that this early introduction is effective. Of course, there is no ideal study. So one of the questions people are asking is how relevant is early peanut introduction in countries with low peanut allergy prevalence? Well, the best would be to repeat the EAT study in countries with a low prevalence. Of course, it's not so easy, so we have to find the solutions. And if you look at the recommendations on potential introduction of potentially allergenic foods from different organizations, you will see that they are very consistent, that allergenic foods should be introduced around 6 months, but not before 4 months. Of course, there might be some differences between different recommendations, but generally, this is a direction into which they go. And again, I would like to focus on the most recent recommendation from IACI. And again, it only focuses on IgE-mediated food allergy. So the IACI task force suggests against restricting consumption of potential food allergens during pregnancy or breastfeeding in order to prevent food allergy in infants and young children. And there are also some specific recommendations for hen introduction. So the IACI task force suggests introducing well-cooked hen's egg, but not pasteurized or raw egg, into the infant diets as part of complementary feeding to prevent egg allergy in infants. And according to the studies, it appears that the best age to introduce egg, also peanut, which I will discuss in a moment, is from 4 to 6 months of life. And what is really important, it has to be well-cooked hens, well-cooked egg. For peanuts, in population with a high prevalence of peanut allergy, the IACI task force suggests introducing peanuts in an age-appropriate form as part of complementary feeding in order to prevent peanut allergy in infants and young children. And again, allow me to repeat, according to the studies, it appears that the best age to introduce peanuts is from 4 to 6 months. And what is recommended is 1 heaped teaspoons of diluted peanut butter, for example, each week. So these are practicalities of how these peanuts may be recommended. So my summary number 4 for this part of my presentation, which is timing of introduction of complementary food, that sooner rather than later. And if you look at the dictionary, what does it mean? Sooner without too much delay. So this is what is currently recommended. Okay, so I discussed exclusive breastfeeding. I discussed the use of dietary products with reduced allergenicity. I discussed timely introduction of complementary food, and I showed you what is the evidence, what are the recommendations. There are other early nutritional strategies for preventing food allergies. And again, I would like you to reflect on the following statement. There is sufficient evidence to recommend routine supplementation with probiotics during pregnancy, lactation, and early life to prevent the development of allergy in children. And again, please consider whether you strongly agree, you are undecided, or you disagree. In your opinion, there is sufficient evidence to recommend routine supplementation with probiotics. And as before, let me now comment on the evidence. So if you look at the evidence, there is no recommendation for or against prebiotics, probiotics, or symbiotics, also for vitamin and fish supplements. And this applies to pregnant and or breastfeeding women and or infants. And of course, we are here in the recommendation, all probiotics, all prebiotics, all symbiotics are discussed all together, but each one of them has to be evaluated separately. But even when we look at individual data, there is no sufficient evidence to recommend any one of those, any specific prebiotic, probiotic, or symbiotic. So no recommendation for or against. So my summary number 5 for this part of my presentation is for other intervention. I guess it's true that what they say, if you wait long enough, everything changes. So it's very likely, because there are many studies ongoing, that in the future it may change. So the question is, where are we now when it comes to allergy prevention? We believe this resolves all remaining questions on this topic, and no further research is needed. Well, this is what all of us would like to see in any of the papers. It doesn't happen very often, and we are not there yet when it comes to allergy, to studies on allergy prevention. And this comes from the ERT recommendation. Further research is still needed. There remains uncertainty in how to prevent food allergy, and further well-powered multinational research using robust diagnostic criteria is needed. And I showed you, and I discussed some of that, for example, peanut introduction in countries when there is a low prevalence of peanut allergy. To repeat the LEAP study in another population would be really desired, and many other questions which needs to be answered, hydrolyzed formula, for example. Okay, so allergy prevention, what to advise in 2021. Exclusive breastfeeding for 6 months is a desired goal, even if, and they showed you, there is no convincing evidence that it reduces the risk of allergies. For protein hydrolysates, there are differences in the recommendations. EACI in regard to IgE-mediated food allergy, the recommendation is no recommendation for or against. And please know that each formula should be evaluated separately. And I also showed you the results, very new results, a 20-year follow-up of the Gini study, which may contribute to the discussion. Allergenic foods, including peanuts and eggs, around 6 months, but not before 4 months. And all the recommendations are quite consistent. And for food supplements, prebiotics, symbiotics, fish oil, vitamins, there is no recommendation for or against. But even if the best evidence is available, even if the best guidelines are available, it does not automatically lead to improved health outcomes. And this is a slide which I showed every now and then. What are the barriers between evidence and clinical outcome? And there is a role for physician and for patients, or in our situation, for parents of patients. Physicians should be aware of evidence. They have to accept the evidence. And the evidence should be applied. Physicians should be able and act on the evidence. But there is also the role for patients. They have to agree on the evidence of the parents of our patients. They have to agree, and they have to adhere to the recommendation. So once again, many barriers which extend from awareness to adherence. Okay, I can see there are some questions in the Q&A box, so I will try to answer all or at least most of the questions. The assumed number of cow's milk allergic infants is higher than what you have described, 1% of the more than 1% of the infants. Would you say that there is currently an overdiagnosis in cow's milk allergy? Well, as I said, cow's milk allergy is really a common diagnosis in infants and in children. And I would say it's clearly overdiagnosed in many cases, but it's also underdiagnosed in many others. The strengths of the study, which I showed you, the Europe-Preval study, which was carried out in 9 European centers, is that the same criteria were used in all the centers, and its diagnosis was challenge proven. So I think that we can more rely on this data from Europe-Preval than any of the other data. And I told you, I described you what are the problems with the estimation of what is the true prevalence, if it's increasing or is decreasing. So it's very likely that those data from Europe-Preval are much more likely to be true than earlier data. When would you recommend hydrolyzed formula? When is regular formula sufficient? When we are talking about hydrolyzed formula, there are various types of hydrolyzed formula, partially depending on the degree of hydrolysis, partially hydrolyzed formula. The role remains controversial. There is a discussion whether they should be used in the prevention, because the role is, if any, is a preventive role in the prevention of food allergy. There are also extensively hydrolyzed formula, and all current guidelines agree that initial exclusive feeding with extensively hydrolyzed formula with proven hypoallergenicity is a treatment of choice for most infants, for most children suspecting of having cow's milk allergies. There are 2 exceptions, and those exceptions include eosinophilic esophagitis and anaphylaxis. And finally, there are amino acids formula. And amino acid formulas, there are limited recommendations for the use, but they include, as I said, anaphylaxis and eosinophilic esophagitis, but also all those children with symptoms who are not that do not fully resolve on extensively hydrolyzed formula, children with growth failure, with multiple food allergies. So then these are the groups of children who will need amino acids formula. And when is regular formula sufficient? Of course, in all the remaining situation, you can use just the regular cow's milk based formula. In Netherlands, it's very time consuming to diagnose cow's milk protein allergy. Do you know a quicker way to diagnose cow's milk protein allergy? Well, it's not only in the Netherlands. I think it's all over the world. It's time consuming, but I don't have any perfect solution, any quicker solution to diagnose cow's milk allergy. It's always the same. All guidelines are the same, that it should include, of course, medical history, physical examination, and diagnostic elimination diet, but also skin prick test and a specific IgE, both which allow us to assess sensitivity, and last but not least, oral food challenges, which are part of the routine workup. And in order to avoid overdiagnosis or underdiagnosis, these oral food challenges are really extremely important. So, do I know the quicker way? I will repeat again. No, I don't know. The prevalence of cow's milk allergy is about 1% in Europe. How come? I expected this number to be higher. Is it similar to what you see in other regions, for example, Asia? I think I already addressed this question earlier. I think important take-home message is that there are geographic variations in the prevalence of any kind of food allergy. So I think it's important to have the data for the setting, for the country, for the locations that we are working on. And again, I think that that's important in every case for scientific purposes, that we have it challenge proven. What is your definition of cow's milk allergy? I don't know whether it's my definition, but definitely the accepted definition of allergy is that it's hypersensitivity triggered by specific allergen. Cow's milk proteins are one of those allergens, and it involves immunologic mechanisms. So those immunologic mechanisms are important in order to make the diagnosis of allergy. And of course, cow's milk allergy means that the triggering allergen is cow's milk proteins. What is the difference between an IgE-mediated allergy and a regular allergy? I presume the question is about IgE and non-IgE-mediated allergy. So time is important. In IgE-mediated allergy, symptoms usually occur within minutes, maximum up to 2 hours after ingestion of an allergen. And for non-IgE mediated, so it takes much longer. It can be up to 72 hours after ingestion of an allergen. For the most common IgE mediated manifestation of cow's milk allergy, there are acute urticaria and angioedema. The most common non-IgE mediated manifestations are skin or those involving gastrointestinal tract. I have another question. What is the role of soy protein formula? Soy-based formulas which are currently on the market are made from soy protein and do not contain, of course, cow's milk protein and lactose. I think historically they were always lactose-free, and they should not be used in infants with food allergy under younger than 6 months of age. After 6 months of age, these soy protein formulas could be considered mainly because of their lower cost and better tolerability. However, I would like to underline this, that the tolerance to soy protein should be first established by clinical challenge. And infants with IgE-mediated cow's milk allergy are more likely to tolerate soy-based formula than those who are with non-IgE-mediated cow's milk allergy. I also have some questions which relate to rice-based formulas, and they are available in some hydrolyzed rice protein formulas. They are available in some countries. I know that they are available in France, in Italy, in Spain. They are available as food for special medical purposes according to EU regulations. I don't know. I don't think that they are available worldwide, but anyway, it's since more or less beginning of this century, and they are non-cow's milk based formula. And those rice-based formulas, apart from the addition of vitamin D, they are strictly plant-based, so they may be of potential interest for families avoiding animal-based products. When it comes to allergic symptoms, data on the effectiveness in terms of allergic symptoms and nutritional adequacy remain limited. However, generally, and there are, for example, French Committee on Nutrition, which published guidelines that hydrolyzed rice protein formulas are considered suitable first choices for management of cow's milk allergy because of their palatability and lower costs. But again, they are not available all over the world, so it's important to consider. And of course, they may be also considered as a second choice if cow's milk protein-based extensively hydrolyzed formula are not accepted or poorly accepted. And then instead of going into amino acid formula, if available, then hydrolyzed rice protein formulas may be used. There are also some questions with regard to goat milk or camel in the management of cow's milk allergy. Well, there is a general rule, and again, all recommendations agree that preparations which are based on unmodified cow milk or milks from other mammalian species, including goat milk, camel milk, horse milk, buffalo, sheep, as there are many more, or unmodified soy or rice milk, that they should not be used to treat cow's milk allergy. And there are many reasons for that. And first of all, because of the possibility, and there is high rate of positive allergenic cross reactivity, and also because of insufficient nutritional value. And also in many countries, so-called milk beverages, plant beverages are very popular, which are derived from almond or hazelnut, from rice or soy. And they are also not recommended because of the nutritional inadequacy. And there is a recent position paper from North American Society for Pediatric Gastroenterology and Nutrition, and compare, but also in other data, compared with cow's milk, these kind of formulas are milk beverages or plant beverages. They are low in energy and extremely low in protein. And I have also another question on duration of milk exclusion diet. What should be the duration? So once an infant is diagnosed of having any kind of allergy, like for example, cow's milk allergy, and is placed on exclusion diet, so reevaluation is needed every 6 months if the child is younger than 1 year, or every 6 to 12 months from 1 year of age onward, because it's extremely important to determine if the child is a candidate for reintroducing cow's milk. And again, there might differences in various locations, but every now and then people or children are on too long exclusion diet. So for the duration, it's extremely important to reevaluate whether the reintroduction of cow's milk, or I'm talking about the cow's milk because it's the most common in infants and young children, but of course we are talking about any kind of allergy. So once again, I would like to thank you very much for your participation. It was my pleasure to be with you. Thanks a lot. Thank you very much, and see you soon somewhere. Thanks a lot.
We would like to take this opportunity to thank our speaker for her insightful presentation. We would also like to thank you all for taking the time to attend. As your opinion is very important to us, we would appreciate your feedback on this event to help us refine future sessions. A link to the feedback form will be sent to the email address you have provided to register, and will give you access to your CME certificate. So until next time, thank you all for attending, and take care.